We found about 15 years ago now that people who have macular degeneration have elevated levels of iron in their retinas. And that suggested that the iron might be playing a role in macular degeneration because iron can be quite toxic, as in the disease hereditary hemochromatosis. So we started testing whether the iron might be playing a role or whether it might just be a bystander. And one way that we tested this was to generate a mouse model. So we studied a mouse that has a knockout for the gene ceruloplasmin, which it turns out is necessary for exporting iron from the retina. So these mice accumulate iron in the retina with age, and as they get into their older months for a mouse, they develop a retinal degeneration that has some molecular and morphologic features of macular degeneration. So this really suggested more strongly that iron could actually contribute to macular degeneration pathogenesis.
I think that's a novel and generally underexplored area. And how have you tried to look at this clinically?
So I was fortunate to have a couple of patients refer themselves to me because they heard of my interest. So one of them is a physician who is 44 years old, and she was being seen by an ophthalmologist every year because she has a family history of glaucoma. She was anemic, and because of iron deficiency, because she's a vegetarian, and she was given intravenous iron to correct her iron deficiency. And 11 months after that, she developed macular degeneration at age 44, which is really quite unusual. And not just macular degeneration, but many, many drusen. Drusen, of course, are the hallmark sign of macular degeneration, little white dots in the retina. So it's possible that this is a coincidence, but the temporal relationship suggests that it probably isn't. And also we've begun to test this in mice. So when we give mice intravenous iron, we actually can cause a retinal degeneration that shares some features with macular degeneration. Also, there was a patient with a disease called aceruloplasminemia, which is quite a mouthful. And it's like the mice that have a knockout for the ceruloplasmin gene. This patient has no ceruloplasmin. And as a result, like the mice, accumulated iron in his retina. And he too developed macular degeneration at an early age in his 40s. He then died and contributed his eyes to my lab, and we confirmed that he had lots of iron in his retina, specifically the RPE cells, and underneath and above the RPE cells were drusen.
So he had absolutely no ceruloplasmin. Now, are there mesaiform individuals out there that have half functioning, quarter functioning? And would they potentially represent a population that would be at risk for accelerated or premature drusen formation and macular degeneration?
Yeah, that's a really good question that we haven't had the chance to explore yet. Also, people who eat more or less iron may have more or less in their retina. So red meat is the prime source of iron. We absorb iron very efficiently as heme in red meat, and very inefficiently in the free form, which is the form that's in vegetables. So people who eat a lot of meat may have would have a lot more systemic iron. And one study in Australia actually showed that people who eat meat 10 times a week have an increased risk of macular degeneration. Now, they didn't prove that that was because of iron, but it's reasonable to propose that it may have been.
Well, I think this is a remarkable finding. I think it's one that I haven't heard tremendous amount in the lay literature. So there's clearly a real role to be played in getting this information out there and doing further research. What are your personal next steps for you and your laboratory to take this further?
So we are testing drugs to pull iron out of the retinas of the mice to see if they could prevent the retinal degeneration. And one such drug that we put in the drinking water for the mice is remarkably effective in preventing the retinal degeneration in these mice that have hereditary iron accumulation. Kind of surprisingly, the drug also protects the retinas in other mouse models where iron isn't the primary cause of the retinal degeneration. So it seems that iron that's normally present in the retina can exacerbate a degeneration that's caused by something else, like bright light.
What is this compound?
It's called Defarraprone, and it's FDA approved for use in people with high systemic iron levels as a result of the disease thalassemia. And it would be reasonable to ask why should people with macular degeneration use this, or should we do a clinical trial with it? The caveat with this drug is that 1% of patients who take it get reversible agranulocytosis, no white blood cells. So anybody taking this drug has to have their white blood cell count measured once a week. So that's a tall order for somebody with drusen who's going to need to be on this for perhaps several decades.
Are there other agents that perform similar function?
There are other iron chelators, and we're currently investigating whether any of the others might work as well in the mice as the Defarraprone. Another possibility is that some modified form of Defarraprone or a local administration might be protective and not have this systemic side effect.
So tell us about some of the other projects that you're working on.
We're also doing a clinical study where we're looking at people who have high systemic iron to see kind of what percentage of those people with hereditary hemochromatosis or who have received intravenous iron also get macular degeneration. A couple of patients have referred themselves to me because they've had high iron and macular degeneration, but I don't know what percent of the patients who have macular degeneration have high iron. So we need to start addressing that.
Do you have enough patients in order to be able to start making inferences as to the threshold serum iron level that would precipitate a higher incidence of macular degeneration?
No, that's a really good question. And I don't even know if there would necessarily be a connection between serum iron level and retinal iron levels, because the retina controls its iron intake and efflux. And it's, we think, semi-independent of the amount of iron that's in the blood. We do know from mice that if we really add a tremendous amount of iron to the blood, some of it will get into the retina, and that will cause a retinal degeneration. But if the amount is, say, 20% higher than normal or 50% higher than normal, I'm not sure how big a role that's going to play in macular degeneration.
So you're positing that there is in fact a transport issue, that in some individuals more iron is transported from the serum into the retinal microcirculation.
That's
and
correct.
There is what transport system would be affected or would be responsible?
So that's been a major area of study for the lab, to understand how iron is transported from the blood vessels into the retina and then out of the retina. There's only one iron transporter that moves iron from cells to the extracellular space, and that's aptly named ferroportin. And ferroportin can be in turn regulated by a secreted peptide hormone called hepcidin. Both of these proteins are made locally in the retina. And interestingly, hepcidin can be regulated by inflammation and also hypoxia, which are both factors that play a role in macular degeneration. So we think that iron may be dysregulated in the retina in macular degeneration as a result of some of these other forces that are also causing damage in the diseased eyes, the inflammation and the hypoxia.
Well, it's fascinating to think that whether iron is the chicken or the egg in this equation. What do you think?
I think it's both. I think that it can cause a retinopathy like macular degeneration when the levels are very high and when other factors that can contribute to the disease are predisposing. For example, certain polymorphisms in the complement genes in combination with iron may lead to macular degeneration. And we've connected iron to complement recently. We had a paper published in JBC just a couple of weeks ago where we showed that adding iron to RPE cells leads to complement production, increased complement factor 3 message levels, and increased production and secretion of the protein. So I think that in most patients with macular degeneration, the disease is going to be caused by a combination of factors, and that iron is probably one of them in some subset of patients with macular degeneration.
Now that you've identified iron as an important metal in this disease, are there any other metals that could potentially be implicated in some level?
Yes, I mean, there's been some very interesting work on zinc. So it's been shown in the ARED studies that zinc supplementation can be protective. And part of the reason for that could be that zinc can compete with iron for certain binding sites and displace it. And zinc is not redox active, so it's not going to cause the oxidative damage that can be caused by iron. There are also other possibilities for why zinc is protective. Copper is another metal that could potentially be damaging.
Turning to translational implications of your work, what can you tell patients who are listening or learning about this for the first time? What are the current recommendations and what do you see in the future as becoming part of potential clinical practice guidelines?
Right now, our work is, I think, not at the point where we can make firm recommendations that should alter patients' behavior, but I think that reducing red meat intake is probably a good step at this point. We know that people who eat a diet that's high in green leafy vegetables and fruits is protective, and that a diet that's high in red meat is a risk factor. So less red meat, more green leafy vegetables and fruit fits with our hypothesis and is also been shown in epidemiological studies already to be protective. So that's what I would recommend for now. In the future, I hope that we're going to be able to develop a drug that can specifically remove some of the iron that's accumulated over the years in the retina and prevent it from causing or exacerbating damage.
Professor, thank you for your innovative and groundbreaking work. We really appreciate you spending the time with us today.
My pleasure, thank you.